It is 2 a.m. on the oncology floor. You're just, standing in your patient's room, running a routine fluid bag.
Right, and it's quiet.
Yeah, the patient is resting. But something is just different. Their baseline has shifted.
Like a really subtle increase in their respiratory rate, maybe?
Exactly.
Mm.
Or, a new kind of quiet complaint of a dull ache in their lower back. And you're the only one in the room.
Which is terrifying when you're new.
Oh, completely.
Yeah.
But the clinical judgment you make in those next 5 minutes could literally be the difference between a minor intervention and, well, a catastrophic crisis.
It really could.
So welcome to the Super Nurse Podcast. Today, we're looking at how to make that exact clinical judgment, right? Building a mental framework so you don't just panic in those quiet 2 a.m. moments.
Because the panic doesn't help anyone.
No, it really doesn't. And I do want to make sure we give credit right at the top here. Today's focus is built from the incredible work of Brooke Wallace.
Yes, she's amazing.
She really is. A 20-year ICU nurse, an organ transplant coordinator, clinical instructor, and a published author.
And we should probably clearly state that we are not Brooke Wallace.
Good point, yeah. We are definitely not.
But we are using her bedside knowledge, her clinical notes, and her specific teaching style to help you out today.
Yeah, whether you're a nursing student or a brand new nurse, we want to help you translate all that heavy textbook theory into actual real-world patient care.
Which is so needed.
Before we jump in, guys, make sure you hit subscribe and definitely go watch the comic book-based video of this exact topic on YouTube.
That's so good.
It is. The channel is called Super Nurse Comics, and the link is right down in the description. You really won't want to miss the visual breakdown of what we're covering today.
So oncology, it can feel, overwhelmingly complex.
Intimidating is the word I'd use. Walking onto that floor for the first time. Yikes.
Oh, absolutely. But our mission today is to help you recognize oncologic emergencies through pattern recognition.
All right, so we aren't just memorizing lists of symptoms. We are learning how to think.
And that mental framework, it really starts with understanding the most immediate, silent killers.
Which usually stem from the treatments themselves, right? Not just the cancer.
Exactly. Clinical experience shows us that when systemic chemotherapy hits the body, it effectively just, shuts down the bone marrow.
And the bone marrow is basically the body's high-speed cellular factory. So when that shuts down, you see pancytopenia, which is a lack of all blood cells.
All of them.
Yeah. I always think of it like this. Your red blood cells are the body's cargo ships, right?
Yeah.
Carrying oxygen. Your platelets are the mechanics, patching up the microleaks in the vessels.
I love that analogy.
Thanks. And your white blood cells, well, they're the soldiers fighting off invaders.
So when the mechanics vanish and the soldiers are just completely wiped out, the patient becomes a ticking time bomb.
Let's talk about those wiped out soldiers first.
Yeah.
Neutropenia.
Yeah, so neutrophils are your first responders. When a patient has virtually no white blood cells left, they cannot mount a normal inflammatory response.
Meaning you won't see the usual signs of infection.
Right. You will not see pus at an infected IV site because, pus is literally just a collection of dead white blood cells that sacrifice themselves fighting an infection.
Oh, wow. No soldiers, no pus.
Exactly.
Yeah.
And no localized swelling either.
Okay, wait. I need to stop you there because this is a concept that always tripped me up in school.
Okay, what is it?
So a neutropenic patient has virtually no white blood cells, right? But isn't the fever caused by white blood cells releasing pyrogens into the blood?
Yep, usually.
So how can this patient even mount a 100.4-degree fever if they have no immune system left to trigger it?
That is a fantastic physiological question. You're right that circulating white blood cells usually release those pyrogens.
Right.
But in a profoundly neutropenic patient, the invading bacteria themselves release exogenous toxins.
Oh.
Yeah, and those toxins can travel directly to the hypothalamus in the brain and basically just hack it. They reset the body's thermostat.
That's crazy.
And on top of that, the tissue cells that are being destroyed by the bacteria can release their own local inflammatory markers.
So while the massive immune army is gone, the neurological alarm system in the brain still works.
Exactly. That is why a single temperature reading of 100.4 degrees Fahrenheit or, 38 degrees Celsius is a blaring siren of an emergency.
So you don't just give them Tylenol and wait an hour to see if it comes down.
Never, never, ever.
Right.
In clinical practice, the strict protocol for a neutropenic fever requires drawing blood cultures immediately, and you have to have broad-spectrum IV antibiotics hanging and infusing within 60 minutes.
Because time is tissue.
And here, time is life. Sepsis moves incredibly fast when there's no immune barrier to slow it down. The bacteria just multiply unchecked in the bloodstream.
Man, okay, so that covers the missing soldiers. What happens when the platelets are missing?
That brings us to thrombocytopenia. When platelets drop dangerously low, the patient loses the ability to form clots. So when you walk into the room and assess the skin, you're looking for petechiae.
Those are the tiny, pinpoint red or purple dots, right?
Yeah.
Usually on the lower legs or abdomen.
Yep, those are the ones. Crucially, though, they are non-blanching.
Meaning if you press 2 fingers on them, the redness does not fade away.
Exactly. Because it's not inflammation, it is actual blood outside the vessel.
Oh, the microscopic capillaries under the skin are just spontaneously microhemorrhaging.
Yeah. You might also see oozing from an IV site or bleeding from the gums when they brush their teeth.
But the real terror here is how quickly thrombocytopenia can cascade into disseminated intravascular coagulation, or DIC.
DIC is such a paradoxical nightmare to understand when you're a student.
It really is.
Yeah.
The patient is bleeding out everywhere, but the word coagulation is in the name. How does that actually work at the bedside?
It's essentially a massive overreaction by the body. An underlying trigger like sepsis or severe cancer progression causes the body's coagulation cascade to basically panic and turn on all at once.
So the body starts forming millions of microscopic blood clots all over the systemic circulation.
Right. But because the patient is forming so many microclots, they rapidly use up every single available clotting factor.
And all their remaining platelets. So they exhaust their entire supply of mechanics in one go.
Yes. Once the clotting factors are depleted, there's nothing left to stop normal bleeding.
Wow.
So they begin hemorrhaging from everywhere. Their coagulation labs like PT, PTT, fibrinogen, they'll just change by the minute.
Which means your nursing priorities have to shift heavily to extreme prevention.
Oh, absolutely. Strict bleeding precautions.
Right, so no straight razors for shaving, electric only, no intramuscular injections.
And you avoid inserting Foley catheters if at all possible, because just the trauma of insertion could cause severe internal bleeding.
You even have to be careful with how frequently you cycle the automatic blood pressure cuff, don't you?
Yes, because the squeezing can cause massive bruising. And honestly, you literally clear the room of clutter.
Right, because a minor bump against a bedside table could cause a life-threatening internal hemorrhage in a profoundly thrombocytopenic patient.
It sounds extreme, but it's the reality. Now, while the blood acts as the systemic highway for those emergencies, we also have to look at the physical real estate of the body.
Right, because tumors take up space.
They do, and when they grow into vital areas, they create mechanical blockades.
This is where geography becomes the enemy. A tumor in the wrong place compresses nerves or organs. But I want to look at this from the perspective of a busy floor nurse.
Okay, let's do it.
Patients complain of back pain all the time, right? They're sleeping in uncomfortable hospital beds, they're stressed out, they aren't moving much.
Yeah, it's super common.
So how does a bedside nurse distinguish between a normal musculoskeletal ache from a bad mattress and an actual catastrophic spinal cord compression?
The distinction lies entirely in a hyper-focused assessment. With spinal cord compression, the tumor is growing into the epidural space and physically crushing the spinal cord.
So the pain is different.
Very. The back pain associated with this is typically either entirely new or it's distinctly severe, localized, and it escalates when the patient lies down.
Interesting.
But the ultimate red flags are the accompanying neurological changes.
Okay, so we're talking about weakness in the legs or sensory changes like a sudden tingling, numbness, maybe a feeling of pins and needles traveling down their limbs.
Yes, and the absolute most critical do not ignore sign is a sudden loss of bowel or bladder function.
Wait, really? Just sudden loss?
Yes. The nerves in the lower spinal column, the lumbar and sacral nerves, are directly responsible for maintaining the tone of the anal and urinary sphincters.
So if that nerve bundle gets crushed by a tumor mass, the signal is just cut.
The sphincters relax.
Wow. So if your patient suddenly becomes incontinent of stool, or conversely, if they suddenly retain urine and cannot void at all, you need to escalate that immediately.
Immediately. It is a permanent paralysis risk if that spinal cord is not surgically decompressed or treated with emergency radiation right away.
That is such a huge catch for a nurse to make.
And tumors don't just crush nerves, they can block the body's plumbing too.
Right. Bowel or urinary obstructions are frequent emergencies, especially in abdominal or pelvic cancers, like ovarian or colon cancer.
And for those, you're watching for sudden shift from the patient's normal baseline.
Like sudden, intractable vomiting, or severe abdominal distension that makes their stomach look tight as a drum.
Exactly. Absent urine output, severe localized pain, or labs showing declining renal function because the urine is physically backing up into the kidneys.
In oncology, there is a word you really must learn to respect, and that word is persistent.
Oh, that's a great point.
If a symptom persists despite standard nursing interventions, it is a massive red flag.
Yeah, tracking inputs and outputs and asking about daily bowel habits that is not just busy work to fill out a digital flow sheet.
You are the detective. If a patient hasn't had a bowel movement in 3 days, and now their abdomen is rigidly distended and they're persistently nauseous,
You aren't just going to offer them prune juice or a warm blanket.
no. You're looking at the clinical picture and thinking, okay, mechanical obstruction.
Exactly. But tumors don't just press against static structures like bones or bowels. They also press against the cardiovascular system.
Right, and if a tumor pushes into the major veins or the fluid spaces around the heart, you get incredibly rapid fluid shifts and oxygenation crashes.
There are three major cardiovascular crises you really need to recognize here: superior vena cava syndrome, cardiac tamponade, and venous thromboembolism.
Let's break down the anatomy of superior vena cava, or SVC syndrome first.
Okay, so the SVC is the main giant vein that drains all the deoxygenated blood from the upper half of the body, the head, neck, and arms, back down into the right atrium of the heart.
So if a lung tumor or a massive lymphoma physically pinches off that main vein, where does all that blood go?
It backs up.
It backs up. When you evaluate the patient, you will literally see the fluid backing up against gravity.
The patient will have profound facial, neck, or upper extremity swelling.
You'll see venous distension, meaning their jugular veins will look bulging and engorged, even when they're sitting straight up.
And they'll complain of a pounding congestive headache from all that pressure in their skull.
Plus a persistent cough or shortness of breath because the swelling extends down into their airway.
Yeah, it's very visual. Then there is malignant pericardial effusion, which leads to cardiac tamponade.
Right. So the heart sits inside a protective fibrous sac called the pericardium. Cancer can cause fluid to rapidly build up inside that sac.
But because the sac is rigid and doesn't stretch easily, that fluid has nowhere to go but inward.
It literally crushes the heart from the outside.
Exactly. And if the heart is being squeezed by surrounding fluid, the chambers cannot expand to fill with blood during the resting phase.
And if the heart cannot fill with blood, it has no blood to pump out to the body.
Which perfectly explains the clinical signs you see on the monitor. You'll see severe hypotension, just a crashing blood pressure, because the cardiac output has tanked.
And you'll see compensatory tachycardia, because the brain realizes there's no blood pressure, so it whips the heart, basically telling it to beat faster and faster to try and make up for the lack of volume.
Yep. The patient will also have orthopnea, meaning they absolutely cannot breathe when they lie flat.
Because gravity pushes that fluid directly against the lungs and heart.
Exactly. And the third cardiovascular crisis is a venous thromboembolism, VTE, or a pulmonary embolism, PE.
Because cancer puts the body into a hypercoagulable state. The tumors release procoagulant factors, meaning blood clots are incredibly common.
So you're looking for unilateral leg swelling.
Like where one calf is suddenly much bigger, redder, and warmer than the other?
Yes. And if that clot breaks off and travels to the lungs, you get a pulmonary embolism.
That's when you'll see pleuritic chest pain that hurts worse when they take a deep breath, unexplained tachycardia, and sudden severe hypoxemia on their pulse ox.
You know, as a new nurse, the sheer panic you feel when a patient's blood pressure drops to the floor and their heart rate skyrockets to 140, it's a very specific, terrifying feeling.
Oh, I remember it well.
But this is where pattern recognition saves you. Panic doesn't help the patient. Systematic assessment does.
Right. If the blood pressure drops and the heart rate spikes, take a breath and look at the patient. Do they have facial and neck swelling with engorged veins?
Then you're thinking SVC syndrome.
Do they have a sudden swollen right calf and sharp chest pain?
You're thinking pulmonary embolism.
Are they orthopneic with muffled heart sounds?
You're thinking cardiac tamponade.
Recognizing those specific patterns empowers you. It tells you exactly the doctor to call and gives you the confidence to tell the physician exactly what they need to know.
Yeah, using your standard SBIR reporting format, situation, background assessment recommendation.
The doctor trusts you more because you aren't just saying, the patient looks bad. You are providing a targeted differential diagnosis based on real clinical clues.
And that confidence completely changes the dynamic in the room.
It really does.
Yeah.
Now let's shift from the visible cardiovascular issues to the invisible metabolic chaos.
Oh, the chemistry side.
Right. This happens when treatments work incredibly well, or when tumors severely alter the body's baseline chemistry on a microscopic level.
Let's start with tumor lysis syndrome, or TLS. This usually occurs right after a patient starts a highly effective chemotherapy regimen for a fast-growing cancer, like leukemia.
I always pictured tumor lysis syndrome like a piñata bursting.
I love that.
But instead of candy, it's millions of dead and dying cancer cells bursting open all at once, dumping toxic levels of their intracellular guts straight into the bloodstream.
It is a phenomenal analogy, because when those cells burst open, they release massive amounts of potassium, phosphorus, and uric acid.
And what we know from clinical practice is that the kidneys get completely overwhelmed trying to filter this sudden metabolic sludge.
Let's extend that metaphor a bit to explain the mechanism.
Okay, go for it.
Think of the kidneys like a standard paper coffee filter. Under normal conditions, they filter waste perfectly.
Right.
But if you suddenly dump a solid pound of thick, crystalline sludge, that uric acid and phosphorus, into that filter, it completely clogs. The fluid backs up.
And that is your acute kidney injury.
Exactly. You monitor that by watching for a dropping urine output and a rising serum creatinine.
But you also have to watch the telemetry monitor like a hawk, because that bursting piñata also released massive amounts of potassium.
And potassium dictates the electrical resting membrane potential of the heart muscle.
So if the potassium in the blood spikes too high, the electrical gradient gets destroyed, which can cause lethal dysrhythmias like ventricular fibrillation.
You'll also see severe electrolyte abnormalities causing intense muscle cramps, profound confusion, or even seizures.
It's just a whole system overload. Another major metabolic emergency you have to watch out for is hypercalcemia of malignancy.
Right. This happens when the cancer, often metastatic bone cancer, breast cancer, or multiple myeloma, actively invades and breaks down the bone tissue.
So as the bone dissolves, massive amounts of stored calcium flood into the bloodstream.
The trick to understanding hypercalcemia is remembering that calcium acts almost like a powerful sedative to the nervous system and the muscle tissues when there's way too much of it.
Right, everything slows down.
Let's look at why you see specific symptoms. It paralyzes the smooth muscle of the gastrointestinal tract, causing severe constipation and absent bowel sounds.
Makes sense.
It slows down the central nervous system, leading to profound confusion, lethargy, and severe muscle weakness.
And it causes polyuria, frequent massive urination, which always confused me until I learned the actual mechanism.
Oh, the kidney effect.
Yeah. High calcium physically impairs the kidney's ability to concentrate urine. The kidneys basically lose their grip on water, so the water just flushes straight out of the body.
So the patient pees constantly, which paradoxically leads to severe, life-threatening dehydration.
The bedside logic for both tumor lysis syndrome and hypercalcemia is that these emergencies are found in the daily lab values and in your subtle shift-to-shift neurological assessments.
Long before the patient ever pushes the call light to say they feel sick.
Right, you have to catch the trend before it becomes a full system crash.
Which leads us to our final frontier of oncologic emergencies.
Yes, the newest stuff.
Mm-hmm.
As oncology evolves with cutting-edge therapies, we're seeing entirely new types of crises. We need to talk about CAR T-cell treatments and immunotherapies.
Let's give CAR T the room to breathe here because the science is staggering. CAR T stands for chimeric antigen receptor T-cell therapy.
It's wild.
The medical team extracts the patient's own immune T cells, takes them to a laboratory, and genetically re-engineers them to recognize and attack the specific proteins on the surface of the patient's cancer cells.
They turn the patient's own cells into targeted assassins.
They multiply them by the millions and infuse them back into the patient.
It is absolute science fiction happening in real time.
Mm-hmm.
But because these assassin cells are so aggressive, they can trigger cytokine release syndrome, or CRS.
CRS is essentially the newly weaponized immune system going into absolute overdrive.
It recognizes the cancer and attacks it so fiercely that it releases a massive storm of inflammatory cytokines.
And the collateral inflammatory damage to the rest of the body is immense.
That when you walk into the room, you will see a sudden, extremely high fever, massive hypotension because all the blood vessels are dilating from the inflammation, and severe hypoxia as fluid leaks into the lungs.
The patient goes from looking stable to looking critically ill in a matter of hours.
And along with CRS, these cellular therapies can trigger ICANS.
ICANS stands for Immune Effector Cell-Associated Neurotoxicity Syndrome. The focus here is on the neurological fallout.
Right, because the inflammation makes the blood-brain barrier highly permeable, allowing those toxic cytokines to flood directly into the central nervous system.
The clinical signs are intense. You're looking at severe confusion, profound weakness, or sudden seizures.
You'll often see aphasia, where the patient suddenly cannot find their words or speak clearly.
But the assessment tool used to catch this early is remarkably simple.
I was reading through the clinical notes, and the most surprising assessment tool for ICANS isn't a complex MRI scan. It's handwriting.
It is incredibly practical and highly effective. As part of the strict neurological assessment for a patient on these cellular therapies, you'll have the patient write a simple sentence on a piece of paper every single shift.
Something standard like, "I love my dog," or even just their full name.
And you just compare today's sentence to yesterday's log.
Why does that work so well?
Because the neurological decline in ICANS begins in the subtle microconnections of the brain.
Okay.
Before a patient loses the gross motor ability to speak or swallow, their fine motor control and their cognitive processing start to slip.
So if their handwriting on Tuesday morning is neat and perfectly legible, but by Wednesday morning they're missing letters, drifting off the line, producing a scribbled mess.
You have caught ICANS early. You caught the cognitive slip.
That is such a powerful example of nursing assessment. It costs absolutely nothing, it takes 10 seconds, and it can literally save a patient's brain function.
It perfectly illustrates everything we have been talking about today.
You don't need to have every single pathophysiological pathway perfectly memorized to be a great nurse.
Yeah.
You just need to know the patterns.
You need to know that a 100.4 fever in a neutropenic chemo patient means immediate action.
You need to know that new back pain with leg tingling means you escalate for a spinal cord compression.
You need to know that dropping urine output after chemo starts is a massive metabolic red flag.
The goal is for you to walk into that room at 2 a.m., see the subtle shift in the patient's baseline, and say, okay, this matters, this is an emergency, but I know how to think through it now.
Right. I know what to look for, I know why it is happening, and I know exactly who to call.
Now, there's one final, deeper clinical reality we need to leave you with, looking at the bigger picture of patient care.
Yeah, this is important.
We have spent this entire time talking about how to rescue a patient from these emergencies, but clinical experience shows us that sometimes patients make a completely different choice.
Cancer treatments can be highly toxic, and the emergencies they cause are terrifying and exhausting.
Sometimes a patient will look at their overall prognosis, look at the invasive interventions required to save them from a massive spinal cord compression or severe septic shock, and they will choose their quality of life over further aggressive therapy.
Which is a valid, profound clinical choice, but it completely flips the script for you as the nurse.
So here's a thought to leave you with, something to really mull over on your next drive to work. As you master these emergency protocols, as you learn exactly how to be the hero that catches the subtle signs and saves the day, how will you mentally and emotionally adapt if your patient actively decides against treating an oncologic emergency?
How do you shift your own nursing practice from being a curative rescuer to becoming a palliative supporter, ensuring they have comfort and dignity in the clinical choice they have made?
It is a profound shift in care, and is exactly what makes oncology nursing both the hardest and the most beautiful specialty in medicine.
Well said.
We want to warmly thank you for spending your time with us today on the Super Nurse Podcast. Remember, the knowledge you build today is the safety net your patients rely on tomorrow. Don't forget to subscribe, and please go check out Super Nurse Comics on YouTube to see the visual breakdown of everything we discussed. Until next time, keep observing, keep questioning, and keep being super.